Hello guys. So now we'll start with general pathology. So where we'll be discussing about the cell and its cell pathology. Then we'll go for neoplasia, that is the cancers. What are the general pathologies that we can see in the cancer, we'll discuss here. And systemic cancers and systemic neoplasia we'll discuss in that particular systems. Okay. So we'll start with general pathology. The first thing is cellular adaptations. Okay, so cellular adaptations is the first topic where the cells will go and adapt itself into increasing size or increasing its number. So hypertrophy is nothing but increase in size. Okay, hyperplasia is increasing in number of the cells. Metaplasia is cell changes its form, whereas dysplasia is cell changes its size and shape. Okay, so please do not confuse from metaplasia and dysplasia. Metaplasia is cell changes its form, okay, from squamous cell to columnar cell. If it changes, it is going to be metaplasia, whereas dysplasia is nothing but changing its size and shape. So one of them will be long, one of them will be short, in that way. Okay, for example, if it is squamous cell, then suddenly it changes due to some pathology into columnar cell, then it is going to be metaplasia. Okay, these are the two things I want you guys to remember. Okay, do not confuse metaplasia with dysplasia. Then coming to you, one of the best example with respect to hypertrophy and hyperplasia is in uterus during pregnancy. We will see both hypertrophy and hyperplasia. Okay, please remember that example of both the things. Okay, then moving on, if cell fails to adapt, then we'll be having cell injuries. Okay, cell adaptation is very must, but if there is cell damage, then it can go under cell injury. What are the two types of cell injury? Are reversible cell injury and irreversible cell injury. Okay, so it is very must information that you guys must know is the difference between these two, reversible and irreversible. Okay, so in reversible there will be cellular swelling, whereas in irreversible cell injury also there will be cellular swelling. Okay, please do not differentiate based on cellular swelling between reversible and irreversible, because both of this will be having cellular swelling. Then we'll be seeing blebs. Okay, so suppose this is a cell, we'll be seeing outer blebs. Okay, so these blebs are pathognomic to reversible cell injury, whereas the cells with the membrane rupture can be seen in irreversible cell injury. Okay, we can see chromatins getting the DNA material, chromatin clumping can be seen in reversible, whereas in irreversible there is pycnosis, karyohexis and karyolysis. Okay, so this is the order of necrosis that is happening with respect to irreversible. Irreversible, the cell cannot be reversed into proper form again. Okay, so that is the name, irreversible itself. Okay, so whereas in reversible it forms into this form, and if the force that was, or the substance that was causing the injury, if it is removed, if the force is removed, then it might go back into normalcy. That is why reversible. Okay, so this is the major difference between irreversible and reversible. Okay, please remember this in your mind. Okay, then coming to apoptosis pathway. So suppose there is a cell injury or a DNA damage, and finally what happens is the cell decides to undergo cellular death because it is irreversible. Okay, so the damage has happened and finally the cell has to think that it has to go death. Okay, so apoptosis is the pathway that cellular death is happening on its own. Okay, and there is a mechanism it follows. This is an active process. Okay, suppose if the death is not by the cell itself, but due to some external force the cell death is happening, then it is going to be necrosis. Okay, if cell death because of the information from the cell itself is happening, then it is apoptosis. Okay, we had discussed this in biochemistry, right? So there will be p53 RB gene and all, so which will cause apoptosis. If there is a DNA damage that we are suspecting, from G1 phase it will directly go to G0 phase. We had discussed, right, in cell cycle topic that we were discussing. So this is the apoptosis pathway that is being followed. Okay, so let us see how it happens. So suppose there is an insult to the cell, okay, some external force or internal force is happening, there is an insult to the cell and cell decides to die. So how it is gonna die is, so one thing is, if there is a DNA damage, then it is gonna undergo apoptosis, or else the cell is getting a death receptor function activation, then it is gonna go for this other pathway. If there is a DNA damage and it is undergoing death, then it is called intrinsic apoptosis pathway, whereas the death receptor pathway is extrinsic death or extrinsic apoptosis. Okay, intrinsic P53 gene is what maintains this, whereas in extrinsic or death receptor pathway, it is going to be TNF alpha and FAS-L is the or the information that gives the cell to undergo death. Okay. Now, so what happens is, now the DNA damage has happened, the P53 suspects this, that is what we were discussing, right, in biochemistry. This is a checkpoint. Here in the checkpoint, this P53 gene will check if there is if it is a proper DNA, it will tell, okay, fine, you can go for division. Whereas if it is non-proper, it will send back to G0 phase. Okay, so this is the G0 phase that we are discussing about. What it will do is, it will activate box. Okay, so box X, remember X as death, X is death, right? So X is death. Okay, box. Okay, because there is one more thing called BCL2, which is anti-apoptotic. Okay, BAX is a pro-apoptotic, whereas BCL2 is anti-apoptotic. Okay. So now that we know that box is telling the cell to die, what happens is, there is cytochrome C activation. Okay, there is cytochrome C activation, and this will lead to a cascade called executioner caspase. Remember this executioner caspase. Okay, so executioner caspase will get activated. The same thing will happen in death receptor pathway, the extrinsic death receptor pathway also, where TNF alpha and FAS ligand will tell cytochrome C to undergo executioner pathway caspase. Okay, so what it does is, it will form a cytoplasmic bleb and form an apoptotic body. Okay, then finally, after forming an apoptotic body, this cell was there normally, and now it has formed into a body, apoptotic body, blebs are there. So finally, the macrophages, the WBCs will come and engulf this and degrade it. Okay, so this is the main cycle that is being seen in apoptosis pathway. Okay, so one more thing I want you to remember is, failure of apoptotic body to be taken up by the macrophages will lead to a disease called SLE. Remember that, right? SLE, systemic lupus, right? So this SLE will be caused because of this thing only. Okay, so remember that. So this is the apoptotic pathway. Then marker for apoptosis is unhexin 5. Okay, so there is a marker for apoptotic pathway, it is unhexin 5. Okay, so remember that extra point. Okay, then coming to, we are done with the apoptosis. Now we'll go for necrosis. Apoptosis was an active process, whereas necrosis is a passive process. There is no energy required for necrosis. Okay, so this is damage has already happened, and the cell died because of the insult from an external factor. Okay, now remember, macrophages took up the apoptotic bodies, right, and degraded it. Here it is the inflammasomes which will clear the necrotic cells. Okay, this is known as pyroptosis. Okay, pyroptosis. Remember this caspases I told you, right? This is both in necrosis and in apoptosis. Okay, caspases will be there both in pyroptosis and also in apoptosis. Okay, please remember that, an extra point. Okay, then what are the types of necrosis? this we have been studying since our second year, right? All the types of necrosis, gangrenes and all. So types of necrosis are coagulative necrosis, caseous necrosis, liquefactive fat necrosis and fibrinoid necrosis. Okay, it will be easier when you learn the example of it. Coagulative necrosis is all the tissues. Okay, wherever there is a necrosis in our body, skin, muscle and all, it will be coagulative type of necrosis. Whereas brain is the only organ which will undergo liquefactive necrosis. Okay, remember in that way. Brain will be having too much fluid, right? CSF and all. So remember in that way. So that is why brain will undergo liquefactive necrosis. Caseous necrosis, you know that, right? Granulomatous and caseous formation will be there, non-caseating, caseating granuloma, lungs. So remember in that way. So caseating granuloma, TB, caseous necrosis. Okay. Then fat necrosis is pancreas. Pancreas is made up of fat. Breast is made up of fat. So that is why it will undergo fat necrosis. Then the fibrinoid necrosis is vasculitis. Okay, so remember these examples. Okay, so that's it. You are done with apoptosis and necrosis. So let us discuss about in general pathology. So we are basically discussing about all the general topics that might lead to pathology, and what are the things if a pathology is there in a person, in a patient, what are all the things that are that is going on we should be suspecting. So now we discussed that there might be cell injury that has happened, or cell adaptation that failed to happen, or we discussed about the two types of apoptosis and necrosis that might happen in a pathology suspected in a patient. So now let us see the inflammation part of the pathology. Okay, so if a patient is suspected with inflammation, these are the things that will be there. Okay, interleukin 1, 2, 6 and 8 are pro-inflammatory, whereas interleukin 3 and 4 are anti-inflammatory. Okay, remember that, an extra edge point. So then doctor, remember doctor, when you go to a doctor, if you are going with an inflammation or infection, so first thing he'll see is a doctor. Okay, so doctor will see doctor. Okay, what is that? Dolor, calor, tumor, rubor, you know that, right? So we are suspecting a inflammation. For example, some swelling is there in a patient. What we'll see? Dolor, pain. Then color of the skin, or sorry, not color of the skin, temperature of the skin, that swelling particularly. Tumor is the swelling, whereas R is redness, rubor is redness. So doctor is seeing doctor. Okay, when we go with an inflammation in our body. So that's it. Remember this thing. Okay, then there are two types of inflammation. One is acute inflammation, whereas another one is chronic inflammation. Okay, so let us see what is the cascade that happens in acute inflammation. Okay, there is vascular dilation that happens during acute inflammation. Then there is cellular leukocytosis. Okay, what is this? Suppose there is an inflammation or an injury that had happened, suddenly there will be swelling in that particular place, right? So what has happened inside the body is what we are seeing. Okay, here in acute inflammation. So what has happened is there is vascular dilatation, and also all the WBCs think that, oh, some invasion has happened. WBC is our body's soldiers. Okay, so that is when all these soldiers get mobilized. Some terrorist attack has happened, so that is why all our soldiers are getting mobilized into that place. So this is what is happening. So let us see how our commandos will enter that particular place and start destroying the pathogen. Okay, so what happens is, first is migration, then adhesion, transmigration, and the finally migration. Okay, so what happens is, so the first thing is not migration, it is margination. Okay, so this is margination that is happening. Margination. So what happens is, these WBC cells, the leukocytes particularly, so they are migrating. So let us take, this is a vascular bundle, and here the swelling is happening, or here the insult has happened. So in the blood, these leukocytes are following, right? So what happens is, they'll start marginating towards the vascular endothelium. Okay, so they'll come near the vascular bundle. Okay, so then after that, after coming near, it will adhere to the endothelium, so it will be fixated to the endothelium. Then the transmigration, it starts going inside. Okay, so it starts, this is the blood vessel, this is the pathogen or the inflammation that has happened. So now the transmigration starts taking place. Then after that, it is going to migrate into different places and trying to engulf all the bacteria and pathogens that is present there. Okay, so this is how the acute inflammation cellular activity will take place. Please remember these 4 steps: migration, adhesion, transmigration, margination, adhesion, transmigration, and migration. Okay, so these are the hormones that are present for these things to happen. E and P selectin will be supporting the margination. ECAM and VCAM will start the adhesion. Then PCAM is what the receptor will be present and causes a transmigration, whereas C5a and interleukin 8 is causing migration. Okay, interleukin 8 function, it is a previous year question. Please remember this. Okay, transmigration is, migration is because of interleukin 8. Okay, then please note the acute phase reactants. Okay, so acute phase reactants are of 2 types: positive acute phase reactants and negative acute phase reactants. Meaning, when there is an inflammation or infection that is going on inside our body, these are certain things that will be raised inside our body. Okay, raised or decreased inside our body. Suppose a patient comes to you and we are suspecting an infection or inflammation, we'll tell them to do these tests. Okay, so to suspect and finally come to a conclusion, okay, the inflammation or infection is happening. Okay, so what we do is, positive is ESR, CRP, procalcitonin and hepcidin. Okay, these levels will be raised in the body, whereas albumin and transferrin will be reduced inside the body. Okay, I told you, right, we'll be doing the PCV in dengue and all we discussed in microbiology, right? So this is the same thing. Acute phase reactants will be raised with respect to ESR, CRP, procalcitonin and hepcidin. Okay, if you would have seen in your internship, we used to send these lab values, right? ESR, CRP, procal and all. Okay, so this is what we were suspecting, like whether the infection is there or not in the body. So this is what we were trying to prove. Okay, then a negative acute phase reactant is these values will be reduced. Albumin and transferrin value will be reduced. Okay, why transferrin value will be reduced, I'll tell you when we are discussing about iron metabolism later in other chapters. But for now, remember, albumin and transferrin value will be reduced. Okay, why both of this will be reduced, I'll tell you later in systemic topics. Okay, for now you remember this is the acute inflammation. Okay, vasodilation is happening, then the cellular event of 4 steps took place, and these are the acute phase reactants that we can see in a acute inflammation. Then going on to chronic inflammation, this is because of persistent infection. Okay, now the acute infection had happened, then finally all the leukocyte took its position and killed all the bacteria that were there, but some of them had remained dormant or remained stronger than our acute reactants. So that is when persistent infection will be there, which will lead to chronic inflammation. So mononuclear infiltration will be there, which will lead to scarring, fibrosis, amyloidosis, neoplasia and granulomatosis. What happens is, there is a pathogen here and around it there is our WBCs and all, but inside they have tried and covered all the pathogens that was there, that was infecting. Okay, they are not allowing it outside, but here itself is the damage is happening, right? Here the damage is happening. So what it happens is, in that particular site there will be fibrosis, amyloidosis and all these things will be happening. Okay, this is called chronic infection. Where can we see this? Best example is TB, sarcoidosis and all these things, right? These are the chronic inflammation where the complete pathogen destruction is not there. Okay, but they have remained dormant but causing infection. Okay, this is where we can see chronic inflammation. So now in granulomatosis, there are two types of granulomatosis. So I told you, right? So around the pathogen, um, our WBCs are there, and inside there will be the pathogen. Okay. So the granulomatosis, this process is called granulomatosis. Okay. So this granulomatosis can be of two types. One is caseating granuloma, the other one is non-caseating granuloma. Okay. Caseating granuloma occurs when the pathogen inside is a microbe. Okay. When it is a microbe, it will be caseating. Whereas if it is a non-microbe, some foreign body is there, or some suspected silicosis, asbestosis, and all these things, right? So if it is a non-microbe or some other protein is there, then it is gonna be non-caseating granuloma. Okay, remember these things. Okay. Because if you remember these nomenclatures and all, it will be easier for you when I go to a systemic pathologies, like in later chapters. It will be easier for you what I'm actually speaking about. I'll speak there also, but for now you remember this is what is happening in acute inflammation and in chronic inflammation. Okay, that is how you should be able to differentiate between the two inflammations. Okay, so that's all about the inflammations. So now let us learn a little about wound healing. Okay, so the inflammation had happened, some insult had happened, so finally the body is healing. Okay, the wound had happened. So now let us see how the whole healing of the wound will happen. Okay, so there are three phases, okay, through which the wound healing happens. First is the acute thing. Immediately what happens is within 3 days there is inflammatory response of wound healing. Okay, so first 3 days will be inflammatory, it will be painful and all the redness will be there, right? So then after that all the pain will and all disappear. For 3 weeks this proliferatory phase will happen. Okay, so inflammatory phase is there, then proliferation is there. Then for around 6 months there is remodeling. All the skin that was damaged and all, right, all the skin, the tissues that were damaged is all getting remodeled. Okay, so these all three phases we can best see in all these ulcers healing and all. Okay, rather than a small cut and all, we can see better of these phases when we are seeing a case of ulcer and all. Okay, so if you want to see a case of it, just go and see these ulcer cases. So and you can track all these three phases. Okay, inflammatory, proliferatory and remodeling are the three phases. Okay, so main thing is I had discussed the same thing in dermatology also, that this healing is happening from type 3 collagen to type 1 collagen. Okay, type 3 to type 1, please remember this. Okay, if I there also I had told you, if this type 3 to type 1 collagen thing is not happening, then it will lead to a pathology called hypertrophic scarring or keloid scarring. Okay, what is the difference between two is, in hypertrophic scarring the scarring is confined to its borders. Okay, suppose if this is the cut wound and now the healing has happened and the healing is here only, but there is too much healing. Okay, too much collagen is forming and a big blob like structure is there. Okay, so that is when we can suspect a hypertrophic scarring. Okay, but if it is going beyond the border, so this was the border, right? So this was the border of the wound. If it is going beyond the border, if it is scarring like this, then it is going to be keloid scarring. Okay, extends beyond the border of the wound. Okay, so these are the two types of pathologies that we can see when there is a the phases would be affected with respect to wound healing. Okay, that's it. Okay, this is the general pathology that we wanted to discuss. All the nomenclatures and all we have discussed. Now we'll jump on to the major thing, your favorite, neoplasia. Okay, I'll make neoplasia too much easy and interesting for you, so that it will be easier for you when we start discussing about the neoplasias of that particular system, like brain cancer, in urology, bladder cancer or penile cancer we discuss, or ovarian cancer in obstetrics, gynecology we discuss. So it will be easier for you when you know all these nomenclatures. So starting with neoplasia, so remember in all the tissues we'll be having two components, that is one is cells and another one is stroma, that is the background or the interstitium around the cell. So there is one cell, there are many cells, okay, let us take in that way, and around it what are the material is there, no, that is called the interstitium, okay, or the stroma, okay. Cells are also called as parenchyma, okay. I want you guys to remember this nomenclature. So parenchyma is nothing but cells, okay. Whenever I tell parenchyma, I'm mentioning cells, okay. Around that whatever I'm mentioning is nothing but stroma, okay. Stroma is nothing but around the cell is what I'm talking about, okay. Then the other nomenclatures are with respect to neoplasia, it is benign, malignant, neoplasia, okay. So if it is benign, then the word would end in oma, okay. Malignant, if it is an epithelium that I'm talking about, then it is going to be carcinoma. If it is a musculocutaneous tissue that I'm talking about, then it is going to be sarcoma. See, all the bone lesions, like for example, let us take bone cancer, best thing that we can take, okay. So if it is a malignant carcinoma, meaning it is spreading or it is beyond its borders that it is going, then it is going to be malignant carcinoma. Benign is it is remaining in its own space, okay. It is not going elsewhere, it is remaining in bone itself, okay. So osteoid, osteoma, because why I am telling this, giving this name is because we have already discussed orthopedics, right? So that is why osteoid, osteoma meaning it is a benign tumor of the bone, okay. Oma. Then coming to malignant, sarcoma. So whatever the word sarcoma is there is with respect to musculocutaneous tissue, okay. Bones, muscles, all these things will come with respect to sarcoma. Whereas carcinoma, okay. So carcinoma, let us take dermatology, we have already discussed squamous cell carcinoma, because epithelial cells of the skin is what is getting involved here, right? So that is why the name carcinoma, okay. So remember in that way. So that is how you can identify, okay, this is the cell that is getting affected, okay. That's it with respect to benign and malignancy. Then the other three names I want you to remember: teratoma, hamartoma, choriostoma, okay. These are previous year questions, please remember this. Teratoma is where all the three germ layers, the first chapter that we discussed is embryology, right? So there we learned about ectoderm, mesoderm and endoderm, right? So if all the three germ layers are involved, then it is going to be called teratoma, okay. Then coming to hamartoma, an abnormal tissue at a normal site, okay. So an abnormal tissue at a normal site, okay. For example, an intestine is there, abnormal tissue, okay, some cancer cell has come in the intestine, so that is known as hamartoma. Choriostoma is a normal tissue, this is a normal squamous cell which is present in an abnormal site. Suppose this is a bone marrow. So if inside bone marrow, if we start seeing all these small intestine columnar cells and all, so it is going to be a normal tissue, but it is at an abnormal site, right? So that is what is called as choriostoma, okay. Abnormal tissue at normal site is hamartoma, whereas the vice versa is choriostoma, okay. Remember that thing, okay. Then coming to malignancy, so note that increase in metalloproteins by the neoplastic tissue, which is the one thing that causes the breaching of basement tissue. I told you, right? Benign is, let us take a bone. If it stays in the bone itself, in that particular layer alone, then it is going to be benign. If it goes beyond the borders of bone and it is going outside, then it is called malignant. Why will this malignancy is happening? Because there is increased metalloproteins, okay. These neoplasia cells will start producing metalloproteins, which when it increases, it will cause the breaching of the basement membrane, okay. This breaching will lead to metastasis. That is what I was telling, right? It can start undergoing metastasis into other places, like it can travel through blood and go to brain, it can go to lungs, so all these things can happen. It is happening because there is increased metalloproteins, okay. So metastasis also in general If it is carcinoma, what did I say about carcinoma? If it is an epithelial cell, right? If it is carcinoma, then it is gonna go travel by lymphatics, or it is traveled by embolic form. Okay. If it is a sarcoma, I told you, right? Bones, muscles. If it is a sarcoma, then we call it a sarcoma. It is because of bones and muscle cancer. So sarcomas mostly travel through blood. Okay. There can also be metastasis through transcoelomic pathway. Okay, meaning from one place to another adjacent structure transcoelomically, it can directly cause the cancer also. Okay, so this is also a method where the cancers can spread. So this is the basic generality of the neoplasia topic. Okay, then we'll dive into the specifics of general pathology, that is gene regulation. Why do the cells undergo cancer, or what is our understanding with cancer till the date of research, no? So this is what our understanding of cancer has been. Okay, so let us discuss about it. So there are gene regulators. I was speaking about P53 gene, RB gene and all, right? That is where this is where those things will come up. Okay, so remember, there are gene regulators. Okay, so what these gene regulators do is they control this division of the cells. Okay, there is one cell, it has to form two cells. Okay, so these gene regulators are the ones that tell, okay, two is there, two is enough, or I need four. Okay, suddenly I need only one. This is the gene regulators that controls how many cells are required or how many divisions are required. In all our human body, in all the cells, these control genes are present. Okay, to maintain the amount of division that it should go under. Okay, so what happens is, when these gene regulators are affected, that is when the cells can undergo as many division as it can, right? So it doesn't have a regulator. So that is when the cells start dividing on its own, and too much cancer cells will happen, or too much amount of that particular cell will be there. Okay, so let us see what are the types of gene regulators and what are the cancers that it might cause. Okay, there are two types of gene regulators. One is proto-oncogene, the other type of gene regulator is tumor suppressor gene. Okay, so let us discuss one by one. So what happens is, in proto-oncogene, this is the normally the gene will increase the mitosis. Okay, so a cell is undergoing one into two cells, then this will divide into four cells, in that way. So what happens is, these proto-oncogenes are the genes that tell the cell to divide. Okay, so now I'll tell an example so that it will be clear for you. RAS is a proto-oncogene. Okay, what it will tell is, normally one mitosis to happen. Okay, so now suppose there is a mutation in RAS gene, then what happens is, there is increased mitosis, because there is no regulator at all. So that is when increased mitosis will happen. Though one more example is ABL-BCR gene, which is in the 9 and 22 chromosomes. Okay, ABL-BCR, if there is a translocation is nothing but a type of mutation. Okay, so translocation is happening, which will increase the tyrosine kinase. This tyrosine kinase is what is required for division. Okay, so tyrosine kinase starts increasing, that is when increased WBC cells, all the basophils, all the type of cells will increase. Okay, tyrosine kinase is required for division of WBCs. Now tyrosine kinase level is increased, so that is when there is no control at all with respect to WBC division. So that is when mature cells, all the things will start increasing. So ABL-BCR gene mutation will lead to CML. What is this CML and all, we'll discuss in hematology. Okay, so CML is where this is the pathogenesis behind CML. Okay, so now you got it, right? So proto-oncogenes, Normal function is to increase the mitosis in a controlled way, but when there is a mutation, there is no controlled way and cell starts dividing on its own. Okay, so this is the pathogenesis. Now coming to tumor suppressor gene, similar thing only, but normally it tells to reduce the mitosis, but when there is a mutation, there is no control of mitosis and the cells start dividing on its own. Okay, so this is what happens in tumor suppressor gene mutation. So best examples are RB gene and P53 gene, which we have been discussing since our beginning of the series, right? So retinoblastoma gene, what it does is, normally we had talked about elongation factor, right? In cell cycle we had talked about elongation factor. In protein synthesis also we had discussed about elongation factor. So elongation, normally what it does is it reduces the elongation factor, there in which the mitosis will be reduced. Okay, but what happens in mutation of RB gene is there is increased elongation factor, which will lead to increased mitosis. Okay, so this is how the pathogenesis of RB gene will happen, which can lead to retinoblastoma, the eye cancer that we see, enucleation and all we have to do, right? You would have seen some of the cases in your ophthalmology during internship also, right? Retinoblastoma and all these cases you would have definitely seen. Okay, so that is how the pathogenesis of that particular cancer will happen. So now moving on to P53 gene. This is very, very important. Please remember this P53 gene. Okay, because I told you, right, we were discussing about cell cycle, where I told you from G1 phase it is going into S phase and then the cell cycle continues. Okay, but I told you there is a checkpoint called P53, where P53 gene will be the checkpoint where it will check the DNA, and if it is proper it will allow the cell cycle to progress, or else it will send back to G0 phase. Okay, and all the apoptosis will happen. What does the P53 gene do? Let us see. What happens is, in G1 phase, normally there are, in P53 gene there are two other genes, which is P21 and another one is GADD45. Okay, so remember this. Okay, what happens is P21 makes the cell to arrest. Okay, so this cell cycle is moving, suddenly it will tell, oh hey, wait a minute, stop. Okay, so after arresting that cell, then it will check for any defect is there or not. Okay, after checking, if there is a repair required, then it will tell GADD45 to repair it. Okay, then the GADD45 is like a mechanic and it will start repairing that gene. Okay, suppose if the gene, if the DNA is not repairable, then it will tell the cell to go apoptosis. That is what we discussed in the beginning of this chapter, right? Apoptosis pathway and all. So there is where the P53 gene came. Okay, so this is what the apoptosis pathway looks like. Then if it is successful, then it will go to formation of the cell cycle will continue, and this P21, GADD45, P21, all this will degrade. Okay, so in that way, if it is successful, it will allow the cell to continue. If it is unsuccessful, it will tell the cell to go under apoptosis. That's it. So this is how the P53 will work. When P53 is not working, that is when the checkpoint is not there, all the damaged DNA is also undergoing division, so that is when the cancer is happening. Okay, so this is how the cancer happens. So you got an idea, right, how the cancer might happen. There are hundreds of other genes also. You remember only these 4 genes, with 2 with respect to proto-oncogenes and 2 with respect to tumor suppressor gene. This is more than enough. Okay, like with respect to what pathogenesis these genes will lead to. There are other genes also, like a MYC gene, all these things are there. Okay, BCL2 and all these things will cause many different cancers. Okay, so if you want a list of it, please Google it. You will get a list of all the cancers and the gene that the particular cancer is affected in. Okay, so what I'm telling is, you need not learn all of that. Remember only the important cancer related genes that are affected. Okay, so this is how a particular cancer will occur. Okay, and one more extra point I want you guys to remember is, there is a syndrome called Lee-Fraumeni syndrome, which is where inherited P53 mutation is there. Okay, inheritedly by birth only P53 mutation is there. It is P53 gene mutation happens because of some insult. Okay, some UV ray, some X-ray, or all the food that we eat, coal and all will cause cancer. They are telling, right? All the materials, aluminum, all these materials that we use for cooking and all. So these are the type of insults that the carcinogenesis that might lead to the gene damage. But in Lee-Fraumeni syndrome, what happens is by inheritance itself, the P53 will be mutated. Okay. So those people have high chances of getting cancer because there is no DNA repair that is happening. Okay, so this is the pathogenesis of a neoplasia. Okay, you got it right. Then as I was discussing, all these insults that is happening is because of carcinogens. Okay, the name of the insult is known as carcinogen, which will cause the cancer. There are three types: physical carcinogens, chemical, and biological. Okay, physical mainly is radiations. Okay, so I wanted to remember one point, major point is how the radiations will affect that particular systems. Okay, so bone marrow is most susceptible as compared to GI cells, and then CVS, CNS, and then the muscles. Okay, bone marrow is the most susceptible to radiation. Okay, so that is why blood cancer will be most common with respect to radiations. Okay, in that way. Then one big example for biological carcinogen, EBV, we discussed in microbiology, right? EBV is one of the major organism that might cause cancer. It is a big carcinogen. Okay, that's it. Okay, that is with respect to carcinogens. Moving on. So hallmarks of cancer. Remember, these are noteworthy points. There are many 10 to 15 points of hallmarks of cancer are there. Noteworthy points have taken here. Okay, remember these things. There is something known as Warburg effect. Okay, where the cancer cells, even though we discussed in my biochemistry, right? So when there is oxygen, the glycolysis will undergo formation into TCA cycle, and all the 32 ATPs will be produced. But in cancer cells, even though oxygen is present, glucose, what it does is it goes on to formation of lactate. Even though less amount of ATPs are produced, very less than the 10 ATPs are produced, probably 2, I don't remember the point, but less than 10 ATPs are produced. Even then it is undergoing lactate formation. That is why the weight loss. Okay, so remember, weight loss is happening mainly because of this thing only. Okay, in cancers mainly the weight loss is happening because glycolysis is not producing not undergoing into TCA cycle, rather than it is undergoing anaerobic pathway, that is lactate formation. Okay, so that is why more glucose is required in cancer patients, which will lead to weight loss. Okay, so remember that. And this effect is known as Warburg effect. Okay, this is the main thing that is used in PET scans. Okay, what we are scanning in our body is where the anaerobic glycolysis is taking place, is what the PET scan we are doing, right? So that's it. Then immune evasion is there, meaning our immune cells are supposed to protect our cells from undergoing any of these cancerous divisions. But what happens is our cancer cells themselves will go and bind to these killer cells and tell that no, I am a normal cell. How this happens is PD1 in T cell and PDL1 from the tumor cell will interact and cause the T cell dysfunction. So I'll tell you what is the function of T cell. So T cell was supposed to destroy a cell, destroy a cancerous cell, but now tumor cell is telling the T cell, no, I am good, I am not a bad cell. Okay, so that is when T cell will get dysfunctioned. Okay, so this is what's happening. Immune evasion is happening. Warburg effect, immune evasion is happening. Okay, so antibodies against this interaction is what we are using in immunotherapy. So in cancers we are using immunotherapy, right? So this interaction is what we are trying to cancel out, so that the T cell remains functional and it destroys the tumor cells. Okay, so that is what I want you guys to note down. Okay, moving further, notable paraneoplastic syndromes are paraneoplastic syndromes, meaning all the metabolic disorders that might happen not directly from the cancer cells, rather it is like from the hormones and all that is being released, or the metabolic actions that is happening because of the cancer. Okay, so neurological paraneoplastic syndrome, mainly myasthenia gravis, okay, is because of thymoma, because of the thymus cell carcinoma. Then musculocutaneous disorder, that is acanthosis nigricans, blackening around the skin and all, skin and the nape. This is because of gastric adenocarcinoma and visceral malignancies. This acanthosis nigricans can be suspected. Then hypercalcemia can be seen in squamous cell carcinoma of lung, whereas hyponatremia can be caused by small cell carcinoma of lung. Okay, so you are suspecting a cancer, lung cancer in a patient, and suddenly if you tell them to get the electrolyte function test, if you are suspecting squamous cell carcinoma, then you can see hypercalcemia, calcium levels will be increased. Whereas in small cell carcinoma, if you are suspecting, if you see the electrolytes, you can see hyponatremia. Okay, so in that way. Then when it comes to DIC, that we can suspect in APL. Okay, APL is a type of blood cancer. We'll discuss more about in hematology. So DIC can be suspected here. Okay, then this is all about neoplasia. Okay, so this is all and everything that you need to know about neoplasia basics. You got the idea, right? How the cancer will happen, and how the paraneoplastic syndromes will happen, all the gene regulators, how it is getting affected and all. So this is all about neoplasia that you want to learn in general pathology. Okay, the specific neoplasias will be studying in that particular system. For example, head, neck and face I'm discussing, meaning I'll discuss about neurology. So that is where we'll discuss about brain neoplasia or brain cancers. Okay, so that's it. So now moving on, there is another important topic that the examiners are very interested in asking about, is about aging. Okay, because now new anti-aging tablets and all these drugs have come up, right? So that is where the examiners are interested in. Okay, so they have been asking these questions in INICT and all, so not in NEET, but INICT they have asked. So let us study that also. Okay, so telomerase activity, based on telomerase activity only, we are suspecting the aging. Okay, how the aging process is going on and all. So in aging, the telomerase length will be decreased. Okay, so when you see, if you are suspecting aging in a person, so suppose a 35-year-old suddenly is having skin who looks like an age-old person. So suppose you take a biopsy and test for the telomerase activity, then if the telomerase length is decreased, then you can suspect, okay, there is premature aging that is happening. Or if you take a hair follicle, here also if the telomerase activity is reducing, then we can see that say that there is premature aging of the hair cells in that way. Okay, so when the length is decreasing, you can suspect aging. Okay, whereas see, in cancers, the telomerase length or the activity has been increased, because telomerase activity is nothing but the cell division. It is telling us about the cell division. In aging, there will be reduced cell division, whereas in cancer there is increased cell division, right? So that is what we discussed in neoplasia, right? So telomerase activity and the length will be increased. Okay, this is with respect to telomerase activity. One more thing I want you guys to remember is tumor lysis syndrome. Okay, tumor lysis syndrome, this is a previous year topic they have asked. Okay, so what happens is, this tumor cells, suppose this is a tumor and suddenly it undergoes lysis. Okay, because of chemotherapy that we are giving, immunotherapy that we are giving, suddenly this all starts dying, right? So that is when this tumor lysis syndrome will occur. What is it? It is an onco emergency. Onco is nothing but cancer, right? So post chemotherapy, this tumor lysis syndrome will happen. The clinical features are hyperuricemia, hyperkalemia, acute kidney injury, and metabolic symptoms will be there. Okay, so please remember this. Then what is the management? Please increase the hydration, because there is hyperuricemia. Okay, hyperuricemia is there. That is why we are supposed to This is a toxic material, right? So that is why we have to hydrate and reduce the concentration of that uricemia. Okay, then if not, please remember this is the question that they had asked with respect to tumor lysis syndrome. It is the allopurinol that will give first. This is the first line of drug, but first line that we do is hydration, then we'll do is allopurinol. Okay, if in severe cases, then it is gonna be rasburicase that will give. Okay, rasburicase, please note down this in your sticky note. Okay, this was the question that they had asked. Okay, please remember this thing. Okay, that is all and everything you need to know with respect to neoplasia. Okay, one more other topic finally before ending general pathology is I want you guys to learn about hypersensitivity. Okay, what is hypersensitivity? So there are 4 types of hypersensitivity reaction. This we have been learning from our second year also, right? Hypersensitivity can be of 4 types. Okay, remember this, instead of type 1, type 2, type 3 and type 4, instead of that, remember it as A, B, C, D. Okay, it will be easier for you. A, B, C and D. Okay, type A is all the A's. Okay, allergy, atopy, anaphylaxis, asthma, all this is type 1 hypersensitivity reaction. Type B is antibody B. Okay, blood transfusion, basement membrane diseases like good pastures. More about good pastures we'll learn about in nephrology. But now you remember B for B. Okay, blood transfusion, basement membrane disease and all these things. C for C, complement cascade. Okay, immunocomplex disorders. Okay, we'll learn more about immunocomplex disorders again in nephrology, because there we'll get to see these disorders. Okay, SLE and all these things are lupus nephritis. All these things will be immunocomplex disorders. So C for C. Then D for D, delayed hypersensitivity, which is diagnostic tests that we do, like for example Monto test and all these things. Or some reaction tests that we do are D, right? Diagnostic test. Then donor graft host reaction, this is the D. Okay, type 4 hypersensitivity is what is happening. Then dermatitis is also a type 4 hypersensitivity reaction. That's it. So if you remember A, B, C, D, suppose they are asking a question with respect to anaphylaxis is happening, what is the type of hypersensitivity that took place? Anaphylaxis belongs to A for type 1 hypersensitivity. That is how you remember the hypersensitivity reaction. That's it with respect to general pathology. Okay, then in the second part we'll discuss about hematology. Okay, thank you.